This is Sonia Wagner representing PCA families in one of our recordings that capture lived experience and best practice research-based learning that assists kinship, permanent and adoptive parents and carers in supporting young people. PCA Families has a zero tolerance of child abuse. I'd like to acknowledge the traditional custodians of the land on which we meet and pay respect to elders past and present, and express our intention to move together to a place of justice and partnership. Today, we are discussing health and wellbeing in the caregiving space, whether kinship, permanent or adoptive parenting and caregiving with Dr. Stacy Blythe. Dr. Stacy Blythe is a parent of 8 with 4 biological and 4 non-biological children, and also a registered nurse, associate professor in the School of Nursing and Midwifery, and deputy director of the Translational Research and Social Innovation Group at Ingham Institute, which is essentially an organisation focused on health and wellbeing practices that make sense practically for Southwest Sydney, Australia and the world. Dr. Blythe's research is focused on children in out-of-home care and their families, and she offers insight into infants who are prenatally exposed to harmful drugs. Dr. Stacy Blythe has a developmental trauma postgraduate qualification and develops training for healthcare and social service providers. We're delighted to have you here joining us. Welcome, and what else would you like to tell us about yourself?
Oh, thank you very much. No, I'm just glad to be here. So
good.
That's pretty much me.
Yeah. So you're obviously amazingly talented at juggling a lot of different things. So, and I wonder if you could share with us some of the research that you've identified and how care is offered to newborns and out-of-home care and where that might fall short relative to normal maternal health care offered to birth parents. What should caregivers do about that and how can they help their child?
Sure, great. Thank you very much. So one of the things that I've learned through my own personal experience as a care provider and my experience as a registered nurse is that the supports that we offer to foster carers and adoptive parents and kinship carers as well differs to those supports that are offered to biological families.
Yes.
One really good example of this is nurse home visiting.
Yes.
So in Australia, we have this assumption of universality of our healthcare system, meaning that everyone gets equal supports and that those who require more support get more support. And this is true to an extent, but only if you actually fit the mold. Okay. And so when I refer to families that are socially constructed, those are families that are foster or kinship or adoptive, they don't get those same supports. So in Australia, we have nurse home visiting programs who work with women and infants and the whole family really to help them in those early days after they've given birth.
Yes.
Usually referral happens during pregnancy or shortly thereafter they give birth. And for those families who have good support systems and who are knowledgeable and experienced, they may only have a handful of visits with a nurse.
Yes.
But for those families facing adversity, who have other issues that they might be dealing with, perhaps issues of domestic violence or homelessness or addiction issues or mental health issues, they might have increased visits where the nurse is working with the parents to help them parent well despite the adversity that they're experiencing. The whole idea is to keep the baby front of mind so that they can be a good parent in the middle of a bad situation.
Yes, yes.
But because the referral pathways are usually during pregnancy or at birth, this automatically excludes foster kinship and adoptive families.
Yes.
So one of the things that I'm trying to do is change that and create pathways where we can offer those same supports.
Yes.
And if we think about families in this particular context and the children that are in these contexts, often they have a history of trauma, or they may have a history of prenatal substance exposure. And both of those, and they may have experienced abuse or neglect. All of those things create an environment where those children have increased caregiving needs.
Yes.
But we're not equipping the carers early on to let them know that.
Yes.
So it's about raising that awareness and empowering carers and adoptive parents to be the very best parents and carers that they can be.
Yes, yes, and getting that support and training and information in the early days. So I think often caregivers are also very time poor. So trying to go externally to get support can be challenging in itself. So I assume that system is still based on, taking your newborn to a maternal health centre, that type of arrangement. Is that the case still?
Yeah, so
Yeah.
I did a study recently with carers, adoptive parents and kinship carers across Australia to find out who is accessing child and family health nursing services. And there's
Yes.
different titles for those services in different states, but that's what we refer to them as in New South Wales, where I am.
Yes.
And what we found was that a small percentage, about a quarter of the carers, were taking the children to the community health clinics. And a very small percentage were actually getting visits from nurses in the home.
Okay.
But the majority of the carers were getting nothing.
Right. Okay.
And that was really, really concerning.
Yes.
And out of the sample that we had about 200 carers who participated in the online survey.
Right.
A quarter of them, almost a third, between a quarter and a third, had never had children of their own.
Yes.
So they didn't have prenatal classes. They didn't have, those antenatal classes where you talk about how to feed a baby, how to bath a baby, how to settle a baby. They didn't have that assistance from the midwives or nurses after birth, where they show them how to do those sorts of things. They'd never been educated on how to select formula or even to give a bottle.
Yes.
And so the fact that we aren't giving them that nursing support is a real issue. And when I interviewed these carers, they talked about scenarios where a caseworker would literally turn up at their house with a baby and a tin of formula on a Friday afternoon and say, hey, good luck.
Yes, yes.
And they felt quite overwhelmed.
Yes.
It was really interesting, though, because one of the things that we also found was that our older carers who are more seasoned, like myself, who have had children of their own, who chose to provide care to children in need at a later stage in life, they do have parenting experience.
Yes.
But the rules change. Things change over time. So the age difference between my children was 13 years. And a lot of things changed during those 13 years. The way we sleep a baby, the way that we interact with babies, what we know about how their brains develop has changed a lot. And you forget.
Yes, exactly.
So,
or you need a refresher, or you need
to
just get that confirmation that you're doing the right thing. So
yeah, exactly. So
absolutely.
I think there's a real need for this sort of service in the Australian context.
Absolutely. I'm even thinking, if you go out for a night and you've got a young baby, you leave a whole lot of instructions with whoever is coming in, let alone that situation that you just described where, here you go, here's some formula, see you later.
That's right. It's very, very overwhelming. So,
absolutely. And I think one of the things we talked about last time we caught up was the difference in children who have experienced methamphetamines versus opioids.
Opioids,
can you tell us a little bit about that? Because that's really interesting to learn about and understand. So
well, one of my real keen interests when it comes to health in the out-of-home care system is children who have that history of prenatal substance exposure. There's a syndrome called neonatal abstinence syndrome. And this syndrome describes a constellation of symptoms that babies have after birth if they have been exposed to high levels of opioids, so heroin, methadone, morphine, during pregnancy. They actually experience a withdrawal very similar to what an adult would experience if they were to withdraw from drugs like that. And so those babies present quite irritably. They scream, they cry, they tremor, and they shake. And they often require hospitalization and medication in order to help them through that phase. But what we're finding increasingly in the Australian context is more and more babies who are being born addicted to methamphetamine or ice. And the way that particular drug works on the brain is somewhat different to the way that opioids work. Opioids interfere with our adrenaline and our noradrenaline. And so we are all aware of adrenaline, noradrenaline, because that's what happens when someone cuts us off in traffic, or if we're really excited and our heart starts racing, that's our adrenaline.
Yes.
And so because it interferes with adrenaline and noradrenaline have a lot to do with regular bodily processes. So the reason they become, for example, nauseous and they experience vomiting and things like that is because of the alteration that's occurred with the noradrenaline. But methamphetamine babies don't experience that. So they don't have the same withdrawal syndrome. So these babies are actually very, very sleepy. Rather than screaming all of the time, they sleep all of the time. And they're very sluggish and they progress quite slowly. But for a young baby, they can appear like the perfect baby.
Yeah, very compliant.
They're not crying. And so one of the scenarios that we can see is that we can place a baby with a family who might already have a few children. So you might have a care of 2 toddlers and they might have a school-age child of their own already. And then we place a baby with them and they think, oh, I don't know if I can handle a baby on top, but then the baby's so quiet and placid, everything seems fine.
Okay.
But the danger with babies who are born addicted to methamphetamine is because they are so quiet, they self-soothe and they don't reach out and they don't attach. They don't actively seek eye contact. They don't actively interact with carers. And if you're a busy carer or a busy adoptive parent, you might just take it for granted that this is the perfect baby rather than go out of your way to be stimulating those things. I mean, simple things like learning to pass a rattle from one hand to the other is really important to happen during infancy because it shows the left and the right side of the brain are talking to one another.
Crossing the midline, yeah.
Right. But if we're not telling carers and we're not engaging with carers and letting them know you need to be actively, intentionally stimulating this baby, then we're actually setting the baby up for really poor outcomes. And that devastates carers when they learn later that some of the behavioral issues that they're experiencing are because we didn't have that neurologic stimulation early on.
Yeah, absolutely. Yeah, it's really critical to understand what's gone on for the child that comes into your life. So you can start to create that attachment or additional learnings.
Well, that's right. And, you know, babies who've been substance exposed, whether it's opioids or methamphetamine or, you know, often a cocktail of different substances, don't have the ability to engage with their primary caregiver like a, quote, normal baby would. So when newborns are born, for example, they automatically look for human face.
Yes.
They want to connect.
Yes.
Babies who are born substance exposed don't do that. They look away. They don't want to engage.
Yes.
So it's so important that we teach carers how to make eye contact with a baby who doesn't want to look at them. You know, it's so important. And we're human too. So if you have a baby who is actively looking away, it's really, really challenging for a carer to fall in love with that baby and to attach to that baby. It takes a lot of emotional intelligence to say, this is part of what's happened to this infant, but we can fix this if I stick with it and don't take it personally.
Absolutely.
You know,
and are there some techniques that work in that instance that you kind of recommend? So
I interviewed a carer recently, and she was fantastic. She'd never had biological children of her own, and she's been a carer for 10 years. And she said to me she'd been a carer, I think by the time I interviewed her, for like 14 years, but after about 10 years of providing care to a variety of ages, infants being part of that, she finally came across a therapist who gave her ideas for being able to engage with the baby. And so she had a 6-month-old baby who wasn't giving her eye contact. And the therapist said, get one of those rubber bouncy balls and set the baby on the rubber bouncy ball and hold the baby there. So obviously the baby's old enough to hold their head up. And try to look at the baby. So she's doing this kind of thing, trying to look at the baby. And when the baby finally looks at her, she's told to give the baby a bounce on the ball. Now, babies love that. So you get that positive reinforcement every time I look at my primary caregiver. I get bounced on the ball and my primary caregiver smiles at me and interacts with me. Those things are so important because when we're born, our brains are only 25% developed. There's so much more growing to happen. And in the first 2,000 days or the first 5 years of life, so what happens in our environment dictates the way that our brains become wired. So if children, particularly infants, aren't having those positive experiences, their brain's not going to wire in a, quote, typical fashion, which makes dealing with them when they're older more challenging.
Really challenging. Yeah, absolutely. Wow. And it's so simple to just get that eye contact. And so it's making sure there's a reward attached to that as well, I guess, is what you're doing with the ball. So great. I can think of so many other things we can do with that now. So, and I guess one of the other areas where often there can be treatment that falls short is oral health. And I've had direct experience of that as well. So can you tell us a little bit more about how oral health of children in out-of-home care may be affected?
this is an issue that I've been working on for the last 2 years. And it's surprising to me how little research and how few policies there are to guide caring for the oral health of children in at-home care.
Yeah.
So we recently conducted a review of peer-reviewed literature to see what kind of research was out there related to children's oral health.
Yes.
And we found very little.
Yes.
We found some things that reported they have bad oral health. We have some things that reported their oral health is so severe that they require a general anesthetic and attention in theaters because the teeth are so bad.
Mm-hmm.
So we did a small study, and we interviewed some carers about their experiences, and we found a number of things occur that compromise children's oral health. In Australia, every state and territory is different, but we generally have some sort of health assessment that occurs when a child is placed into care,
mm-hmm.
and a follow-up, more comprehensive health assessment later. Mm-hmm. And it seems like these are pretty consistent, although there are often carers who say that the children haven't been assessed, but they're pretty consistent. We assess them, and we see that they have oral health issues. Yes. But then once they're in the system, the problem is actually accessing services. Mm-hmm. We know that the public health system's got long waiting lists, mm-hmm. and we know that accessing private health services often requires pre-approval from the agency or the government department or whatever it may be. Mm. The other issue that we found is that if we are on a waiting list to see a public health clinician or a public health dentist, that if the child moves, we often lose those appointments. If we go from one place to another, there's no articulation, there's no clear handover. The other thing is, I don't know how many carers are actually going to open the mouth of a child that comes to them and check their teeth when they get there. I think that there's an assumption that there are other things that are more important, like mm-hmm. settling the child and attachment, and all of that is important. Yes. But if we have children with poor teeth who are in pain or who can't eat properly, that's going to affect their behaviors. That's going to interfere with their ability to attach.
Yes.
The other issue is, depending on the age of the child, you've got no idea what kind of oral health training the children have received prior to coming into your care. Mm-hmm. So there may be an assumption that an 8-year-old child knows to brush their teeth twice a day, when in fact, that wasn't something that they had done in their prior placement or before they went into care.
Yes.
So there are so many different issues that can occur.
Yes.
And again, we don't know when we have situations where maybe children are on restoration orders and going back or having regular visits. Mm-hmm. We don't know that the parents have the same sort of oral health training and know not to put juice in a bottle, for example.
Yes.
And know, to follow up and make sure they have healthy foods and so on and so forth.
Yes.
So there's a lot of work to be done in this area.
Yes, absolutely. Even I've had a personal experience where we had to cut down the amount of times we were giving fruit, right? Even something that you think you're doing well or you're doing right for a child can sometimes have an impact. So yeah, because we should have been giving it two or three times a day, not 7 or 8 times a day, right? The acid on the teeth had a big impact. So
that's right. And there's emerging evidence that there's a correlation between poor oral health and prenatal substance exposure as well, which needs to be more explored. But if that is the case, then we need to be understanding exactly what's going on there. I've seen cases of children with poor enamel on their teeth because of prenatal experiences. And if they don't have good enamel on their teeth are just going to rot away. So,
yeah, absolutely.
Yeah, really
and I
important.
guess perhaps thinking about the early childhood educators as well. So, because in my experience, there's been opportunity for early childhood educators to identify some of the oral health problems because they've had those children in care. So, or in front of them on a daily basis. So,
well, and again, going back to our carers and our parents, if they're not actively looking for information about oral health, then they could be missing some of the new things that are out there and that we talk about, the things that we need to be doing. For example, like with infants, we know that we don't want to put juice in a bottle. We know that that's bad for them. We know that we need to not commence solids until they're 6 months old. And yet some of our practices prior to now have been different to that. So if we're not staying up to date with those sorts of things, it can create an issue. And oral health isn't just about brushing our teeth either. I mean, it's making sure that we're eating the right foods and that we're eating them in the right way. And like you said, not having too much fruit, just having everything in moderation and enough calcium in their diet.
Yes.
A lot of these children may have experienced nutritional deficits during pregnancy.
Yes.
And so after they're born, they may still have those nutritional deficits that we really need to make sure that that they're getting the right kinds of nutrients into their diet, because that has huge implications for all of their health, but particularly for their oral health.
Yeah, absolutely. And I guess the other aspect to dentistry work is that there can be challenges for children and adults from trauma. So, you know, if a child's been sexually abused, lying in a dentist chair with your mouth open can feel like a real improper balance of power and could trigger some old memories or anxiety or the fight-flight response. So, you know, even as something as simple as flossing, where you're bringing blood into the mouth, can act as a trigger. So what have you discovered with regards to trauma-informed care needs and oral health? Do you have some advice there?
Well, I think I'm like a lot of people. Just thinking about going to the dentist makes me feel quite traumatized. But I at least have the emotional intelligence to be able to talk myself through it. I'm not a big dentist fan, which is hilarious because I have been supervising dental students. But you're exactly right, though. For a lot of these children who have a history of trauma, one of the big key things about trauma is a lack of control. Because when you experience a traumatic context, you have no control. Children don't have the control to get away, to get out, to fight back often. And that's why trauma is so overwhelming for them. Sitting in a dentist chair where someone has their hands in your mouth and they're doing things that you can't see and they're making noises and maybe even causing pain can be extremely triggering for a child that doesn't have control.
Yes.
So there are a lot of things that we can do. And I think that's probably one of the reasons why a lot of children end up under general anesthetic when they have significant oral health issues, because they need the treatment, but they just can't sit in the chair. So there's a lot of strategies that we can use. We can slowly introduce the children to the dentist. We can take them for a visit, let them sit in the chair, go up and down and play with the light. And that's all we're doing today, because we're just trying to get them used to the environment.
Yes.
Slowly but surely, we should be able to get them to the point where they can sit there. But I can tell you, with one of my children, she had to have a filling, and I think it took us 2 hours to actually get it completed.
Wow.
Because she would get so scared, and it was a lot of talking, and it was a lot of soothing and reminding her that it was okay. But what I found was the dentists are often like, just sit still,
yes.
because they haven't been given any training regarding this.
Yes.
Particularly related to children. Now, we go to a general dentist. I don't go to a pediatric dentist. So it might be that they have a bit more training, and I think that they do. But still, I think there's more to be done. I think all of our healthcare practitioners need training in trauma, but dentists.
Yeah, there are some out there, not a lot, that are trauma sensitive. So personally, I go to a dentist that he gives you a blanket as you lie down in the chair, and he changes his artwork and has artwork everywhere. So the artwork gets changed every 6 months. So you feel like you're going to an experience as opposed to you're going to the dentist.
Almost sounds like going to the spa.
It feels nice. It takes away that that fear, I guess. So I mean, maybe there are ideas for other trauma sensitive dentists maybe to add into the mix. So
we're working towards that. Absolutely.
And are there any other areas where long-term carers may need to be aware of health matters for their children that we could talk about today?
Yeah, look, I think one of the things that we need to really be aware of is that we know so little about history. You know, even though we have, open adoption and we have some things on file about the parents, we really don't know history of a lot of these children. So we need to be really, really committed to making sure that these kids get regular health checks and that we don't make assumptions that everything is okay.
Yes.
One of the things that I have seen and experienced personally is that these children are really good at covering things up.
Yes.
They mightn't always tell you when they have an ache or a pain or if something's not quite right. It's so important to remember to get their eyes and their hearing checked. And I do a lot more health checking with the children that have come to me through the out-of-home care system than I did with my own biological children, because I knew their history.
Yes.
I knew what to expect, and I knew what they were predisposed to.
Yes.
And it's different when the biology comes from someone else. And I think that's really important.
Yes.
One of the things too, we talk so much about attachment, and we talk so much about belonging.
Yes.
And I think for children with a history experience, and for children who have who live with a family that they were not born into, as they reach adolescence, all of those identity issues that just seem typical for any teenager are really so much more complicated for these children. It's not just adolescence. It happens when they go to kindergarten and they have to do a family tree, and they're like, who goes on my tree?
Yes.
That's part of normal society. So it's part of what they have to be able to learn to cope with. But as teenagers, I think it can become exacerbated, because that's really that time of looking for their identity. And so we need to be extra special. We need to be really sensitive and preemptive during that time, and try and have those tough conversations.
Yes.
One of the really key things that I think when I do training with foster carers, one of the things that I think has been most helpful is helping them to understand the concept of executive function.
Okay.
So executive function is it's higher order thinking. It's really boils down to three things. It's your attention span, it's your ability to be flexible in situations, it's mental flexibility, and it's your short-term working memory. Yes. And sometimes when I tell carers this, I get to the last one and I can't remember what it is, and I think, oh, there goes my executive function.
I need to really remember that.
But one of the things that we found, kids who have a trauma history, and that's children who come from the out-of-home care system and who have been adopted, often have trauma history. They have poor short-term executive functioning.
Definitely.
And this creates behavioral issues, or what appear to be behavioral issues, when really it's a neurologic deficit. The great thing about executive functioning is that we can train it. It's like a muscle. The more you practice using it, the more you can improve it. But you have to be intentional. And this is where, again, parenting these children can be a little bit different, because we need to be creating situations where they can use their mental flexibility, or their short-term working memory, or their I see I've lost the third one.
And I guess have success when they're getting the chance to practice those things as well, right? As opposed to failing, if you like. So
well, absolutely. And it looks different across the trajectory. One of the things in terms of health we need to remember is that these children developmentally may be a different age to what they are chronologically.
Yes.
So you could have a 16-year-old in your home who looks like a 16-year-old but acts like a 12-year-old. Yes. You could have a 12-year-old in your home who looks like a 12-year-old but acts like a 4-year-old. And a lot of that goes back to this ability to use their executive functioning. So, a kindergartner, for example, might not be able to follow the rules because they can't control their impulses. Yes. You might have a 16-year-old who wants to go get their learner's permit and learn to drive, but they don't have the mental flexibility to adapt to a changing situation. And it might not be the right time for them. The rule in my house has been, so my eldest son in care has just aged out. He's just finished high school, first in his family. Very proud of him. And
so exciting.
He's a real success.
Yes.
But he doesn't have his driver's license yet. The rule in my house was you need to be able to navigate public transport on your own before we're going to go for your learner's permit. Okay. And he didn't want to do that. He's like, I'll get lost. I'm like, but until you can develop those skills, get on a train and get where you want to go, you shouldn't be operating a car. So he's great on public transport now, and he's working towards getting his P's. He's got his L's. He's about halfway. But it's been the same strategy for his brothers and sisters, because they need to develop those skills. And so
absolutely.
As their parent, their carer, it's my responsibility to be able to say, right, you have a deficit here. We're going to put these things in place to help build those things up.
And let them make the mistake, and then let them have the success. I've had one that went 45 minutes on a bus in the completely wrong direction. But guess what? He never
actually,
makes that mistake
I've done
ever
that
again.
myself. I can tell you, I'm not great with public transport, but but it's a good strategy. It is a good strategy.
He now knows which side of the road to get on when he's going somewhere because he's very observant of it. So,
right. And things like for adolescents too, going for their first job, if they have a poor short-term working memory, but they're really eager to work, unless they actually communicate that to their boss, they could be seen as being lazy. So an example might be a young guy who gets an apprenticeship with a builder. And he's on the job site and his boss says, I want you to move those bricks and set that stuff over there and then go get me a coffee or something. I don't know. 3 different tasks. But with a short-term working memory, after he does the first thing, he probably can't remember what's next.
Yes,
and
absolutely.
if he's wandering around or sitting down and the boss comes back and goes, why didn't you do what I told you to do? He's going to end up losing his job. Absolutely. And then that's bad for their self-esteem and all of that. So it's helping them to understand, explain it so that the boss knows in advance. Yeah.
One of ours was working in a supermarket and my husband had just dropped him off and he turned back to observe him in the produce section and he was on his phone. So he bailed him up when he came home, like, what are you doing on your phone at work? You're not meant to be on your phone. But actually he was employing a strategy which was to write notes that his boss was sort of dictating to him so that he didn't forget what he was asked to do. So he wasn't doing the wrong thing. He was actually, employing a good strategy, which was to write notes on his phone so that he didn't forget all the details of what he had to do. So
and that's such a great strategy. And it's really interesting because people need to understand that if you have it, it's a neurologic disability when you have a deficit like this, and creating those strategies are so important. I've had a lot of carers tell me they're very against mobile phones for children, that they're all too technologically dependent. And look, I totally agree. My kids watch way too much Netflix, and the older kids, I don't know what they see in TikTok, but at the same time, their mobile phones are also their best friend. So I had one of my boys would go to a friend's house or go to the park to play basketball, and he was consistently late coming home.
Yes.
And I'm like, mate, I told you to be home at 5. Why weren't you home at 5? And he's like, I just lost track of time.
Yeah.
He employed the strategy of setting an alarm.
Yes.
He knows when it's time to go. He's never been late since.
Yes.
He wouldn't be able to do that if he didn't have his phone.
Yeah.
So
absolutely.
it's giving them those strategies is what's going to make all of the difference for them. They can function well in the world. We just need to give them those strategies.
Yeah, absolutely. It's part of their world. We have to be realistic too, right? So
that's right. That's right.
Is there anything else you wanted to discuss or highlight today? We've had some great tips there, but is there anything else or any other resources that you think we should be reading or accessing to inform ourselves?
There's some really good websites. There's a couple of organizations that I turn to and look to for updated information. And one of them is the Australian Childhood Foundation.
Yep.
They have some really wonderful training available for carers. I've done their graduate certificate in developmental trauma, and it was just phenomenal. But they have trauma-specific training for carers as well.
Yes.
The other organization is the Australian Research Alliance for Children and Youth, the acronym of ARACE.
Okay.
And they advocate all across Australia and oversee and support a lot of different research projects related to health and well-being and education of children.
Okay.
And there's often really great stuff on their website.
Okay, great.
And if I was to emphasize anything for carers, it's that we need to look after our own health first.
Okay. Yes.
It is super important that we look after ourselves, and it's super important that we model things well to the children.
Yes.
And by that, I mean in moderation. I made the mistake of trying to be the perfect mom when I was young. And I'm watching my oldest daughter, who's now 29 and has 2 children of her own, try to be the perfect mom. And I think, is that my fault? Because I tried too hard. Now there's no worry about the younger kids. They will not be perfect moms because I'm no longer the perfect mom. But modeling things like healthy eating and drinking water and exercise and mindfulness activities, and deliberately going out of our way to manage our own attachment and making sure that those people that we care about who build us up are around us. sufficiently, because our cup
Yes.
needs to be full if we're going to fill the cup of the children that we love.
Absolutely. Yes,
So
for
we need to
sure.
model those behaviors.
Yeah, correct. And as you say, it takes, short periods of time on a regular basis kind of thing. So,
Mm.
it's going for a walk for 5 or 10 minutes,
Yep.
it's sitting down and having a glass of water, as you say, and a conversation. So, yeah, there's so many little things that we can be doing to fill our own cups up. So, yeah.
And
Well,
that's
thank you.
not we see that as spoiling ourselves. Sorry, I know you were
Yes.
about to wrap up.
No,
but
it's all
it's
good.
not spoiling ourselves. If
Correct.
we don't do it, our children aren't going to grow up and do it.
Yes.
So
Correct.
if you feel the need to make an excuse because you sat down for 10 minutes, that's the one.
Yes.
You want to make sure that they do later.
Yes, correct. Absolutely. So I'm just thinking about when I was getting annoyed with the washing machine this week. I sat down and had a cup of tea. So I was modeling, when you're annoyed at the washing machine, have a cup of tea. Well, thank you so much for all those insights. I think they'll be invaluable for all new carers in particular to start to think about, some of those other health aspects to look at and get on top of immediately, so that you can have the best impact on the long-term welfare of the children in your care. So thank you. It's really important information. So
thanks for having me.
You're welcome. And to anyone else making the time to listen to this recording, thank you for giving up your valuable time for the benefit of the young people in your life. Until next time, have an amazing week.